Guys, thank you for joining me for another Ask the Egg Whisperer. You guys, it's Friday, so what does that mean? That means I'm super funny, and let's just call today Sparkle Friday. So every time I say sparkle, you need to take a shot of tequila. I'm just kidding. I don't promote drinking at all. Drinking in moderation, folks, but I'm just trying to be funny and trying to make us laugh. Because I know if you're watching this show right now, you're going through something that's really hard, and that's a struggle to have a baby. And I want to tell you, keep trying and keep going, because it's so worth it and you so deserve it too. So I'm just going to jump right into the questions right now. So first question I have is from Divya, and Divya's question is, I'm 34 years old with PCOS. My hubby is 35 years old, and I've done 6 IUIs. I underwent 2 rounds of IVF, first cycle 17 eggs, none made to blast at day 5. Second cycle 8 eggs, 0 blasts. All fertilized with ICSI. Last cycle I was on omnitrope hormone for 8 days. My RE wants to go for donor egg, but we're not ready yet. He said this poor egg and I can't improve it. He said I was born with it. Genetic screening was clear for me. What should I do? It seems too early for donor eggs. And Divya, I would say I would still consider other options too. Not other options with other eggs, but other IVF protocol options. There's so many other things that you could do. Let's see. Number 1, it sounds like I don't know what, well, let me just start over. It sounds like we don't know if this could be related to, let's say, endometriosis. Maybe consider that as an option. Ask your doctor, what have you ruled out for me? What genetic issues have you ruled out? Is it possible that I have endometriosis? Maybe take supplements that can help with that, like N-acetylcysteine. Consider other supplements that can help with egg quality, like NAD, pterostilbene. I actually have a patient, this is a true story, not making it up, where she had something very similar to this. I think we might have done a lot of cycles, but we didn't give up. And she took these supplements. Again, true story. If you had told me the story, I would say, no, you are making this up. And it worked. And also, like, why are we not thinking that this could be sperm too? Like, have you done a DNA fragmentation test? Have you asked about Pixie or Zymote? So I would consider doing that too. So I think, you know, when you think about embryo quality, we think about age, genetics, and environment. So it sounds like your age is 34. Your hormone levels sound like they're pretty normal. It looks like your doctor has ruled out all genetic things that we can rule out with tests that we have currently available to us. And the only thing that we can change is our environment. So are you exercising every day? Are you following a plant-based diet? Are you taking the supplements that I just mentioned? So those are the things that I would suggest doing. And I still think that there could be a chance for you to have a blastocyst. And I don't necessarily recommend day 3 transfers in all cases, but I think in your case, it might be something to consider because there might be a reason why. So talk to your doctor about how things look on day 3 versus day 5 and see if a fresh transfer is something that they would recommend for you. But great question. I'm sorry you've been through so much, but keep going. This question is from Priscilla. Back in August, I did a test and my AMH came back at 0.9. My FSH was 15. I'm 34 years old. I have super regular cycles. Is there a chance the test is wrong, and do I have a chance of conceiving naturally? And the answer is, Priscilla, yes, there is a chance that there's some lab variation. I'm not going to necessarily say that it's wrong, but to know if it was truly accurate for you, what I would say is repeat it. I encourage people to track and trend their levels. What happens is this, you do one level, let's say one day your FSH is, let's say 9. And the next time you do it, it comes back at 12. And you're like, what happened? Why is my FSH now 12? And what I would say is nothing happened. These levels do this like every month. So don't just rely on one snapshot. I think that's a mistake people make. By not understanding their full diagnosis, well, I should back it up and say, how do you know your fertility diagnosis and how can you understand your egg quality without checking your labs more than once? You know, just one FSH estradiol does not tell you the whole story. And I think sometimes people rely on that and they're like, oh, my levels are great. I don't have to worry. I don't know what's wrong with me. I have this diagnosis of undiagnosed or unexplained infertility. But the reality is if you checked your hormone levels one more time, you might have picked something up that you would not have picked up if you just relied on that first level. So I hope that lesson helps. So this is a question from Nancy. Hi, Dr. Aimee. I'm 34 and I have low AMH, 0.56, and endometriosis, 116 millimeter endometrium on my left ovary. There's no male infertility issue. We just had our first FET cycle and it failed. We retrieved 4 eggs, 2 fertilized, and 2 stopped growing at day 3. I'm sorry. Okay, so this is what I took. DHEA, CoQ10, omega-3, and vitamin D as supplements before starting the cycle. I was on estrase and androgel for priming for 1 month, Menopure 225, and HGH for stimulation. Do you think my endo hurt my egg quality significantly? What caused no day 5 embryo? What will be your recommendation for my next cycle? What type of protocol do you think may work for me? Do you think mini IVF will help me have better quality eggs retrieved due to mild medication? And how many cycles do you suggest before going to donor egg? So Nancy, your question seems to be quite similar to Divya's question from earlier in today's show when I just started it. It seems like you guys both have something called an embryo quality issue, and it could be due to the eggs, but don't forget about the sperm. So look at all the genetic factors like chromosome analysis, sperm DNA fragmentation testing, and do all the things that are in your control that you can do with your environment, like the stuff that I'm always saying, like eating healthy, doing strength training, exercising most days of the week, sleeping, meditating. Those things sound really easy to do, and I know it's easier said than done. But in terms of what to do next, I would say repeat your AMH, consider doing your FSH estradiol level again, see if your doctor could add HGH priming before your cycle, and maybe the estrase priming was too much for you. And what I mean by that, it's possible that being on that dose of estrase and androgel might have suppressed your ovaries a little too much, and your body might have said, I don't really want to grow too many eggs with these hormones on board. So maybe consider doing that, a purely natural cycle start. And yes, I would consider doing something like a mini IVF cycle, not to get mini eggs or like less eggs. I want to do a mini IVF cycle so I can get your whole cohort of eggs to grow. So that would be my approach. So consider like high dose letrozole for 5 days, overlapping with, let's say, 300 units of Menopause, starting the 3rd day into the letrozole, and then go in for your first appointment with the doctor so they can do an ultrasound and see if they should adjust the dose, increase the dose of the gonadotropins, maybe add gonal F, and consider an antagonist cycle. But keep being creative, keep doing what you're doing. And yes, it sounds like this is an egg story, and it could be due to endometriosis, so make sure you're taking supplements to support that diagnosis. So this next question is from Felicia. Felicia is saying, I had a previous IVF fail in August. I'm 37 years old. My husband had no sperm issues. I have secondary infertility as I have a 15-year-old. I was only taking a prenatal my first IVF. We had 12 eggs retrieved, 4 mature, 3 fertilized, 3 arrested, ended up being 100% egg quality. I have another IVF coming up next week. I started CoQ10, NAC, Ovavite. Will these supplements for 2 months be enough to improve egg quality for my next cycle? And I would say yes, I do think that they are. I think whatever you do today will help tomorrow when it comes to eggs. I know there are people that are like, no, you need to be on that for like 2 to 3 months. I'm like, no, I think that in 2 to 3 months, your egg quality could not be as good. So depending on your age and your situation, I do not encourage people to wait for supplements to kick in, because there really isn't a way to tell if they really kicked in or not. But at the end of the day, it's important not to feel like you're being supplement shamed, like you should have taken them for 3 months before. I would say no one would ever say that to you. So keep doing exactly what you're doing. And as far as, knowing that it's an egg quality thing, consider adding NAD as well. True Nitrogen is the company that I recommend right now for my patients. It's just easy to get online. And I would add that to the supplement list that you just gave us. So this next question is from Maria. Maria's question is, I had a tiny piece of retained placenta post-labor removed via hysteroscopy and localized DNC 6 months after I delivered. I had a healthy pregnancy and a live birth for my first PGS-tested embryo. Retrieval was at 29 years of age, and now I'm 31. The doctor prescribed estrase, 4 milligrams daily with 14 days of Keflex, and Prometrium, 100 milligrams for 7 days. She's asking, will this impact my future embryo transfer success in any way? I'll be transferring an embryo from that same retrieval. And Maria, what I would say is no. That's really great that your doctor is that careful that it sounds like, I don't know who found it. You found it or they found it, if you were having symptoms or not. What I would say is it is so reassuring that you had the hysteroscopy, they popped that camera in, they looked around, they looked in the house, they made sure the house was perfectly clean for your next most important guest, which is your next embryo. So my feeling is that your hysteroscopy won't hurt a thing. If you are still worried, if in your gut, if your uterus is talking to you and being like, look at me again, I would say do another saline sonogram before you start your transfer meds. But otherwise, I imagine that your doctor is doing exactly what your body needs to happen, because that's what it sounds like to me. Because what's going on right now is pretty similar to what I would do for you as well. So I'm happy to hear that you had that piece of tissue removed, and I don't think it's going to affect your next transfer. So this next question is from Ashley. Hi, Dr. Aimee. I skipped taking letrozole this cycle because my doctor is trying to see if the letrozole is making my period more painful. I had surgery back in July to take out the endo, but I'm still having excruciating periods. I figured I'd still test, though. I've been testing for ovulation since cycle day 10. I'm on day 17, and I've gotten all no on the test. I felt my cervix, though, and it was high and soft. Is there a chance I still ovulate? And I would say, Ashley, yeah, do the proof test. So that's a really cool test that you can do. It confirms ovulation so that you don't have to, check your cervix, although that is definitely a way of doing things. The other thing that I would consider doing is get a blood test. Easy. So get a progesterone blood test, and then you can not wonder if you've ovulated anymore. It's super easy to do. You don't have to leave your house, though, with the proof test. And the other idea that I have for you is get an ultrasound again, because it's possible that you actually have a cyst on your ovary, and that's preventing you from ovulating. When you have a cyst on your ovary, we make cysts every month when we ovulate, but sometimes you can have a cyst that just sticks around and it's kind of a pain in your ovary. And that's kind of what you're describing, and it can still secrete hormones, and as long as it's secreting hormones, it's telling your ovary not to ovulate another egg again. You see, it just goes round and round and round, and now you're frustrated because you haven't seen a positive OPK, and you want to see that, obviously, for obvious reasons. So I would say pelvic ultrasound, please, get your progesterone checked, and then go from there. But I think what your doctor is doing as far as giving you a break makes perfect sense. But talk to them about IVF. Right? Diagnosis before treatment. Your diagnosis is endometriosis. You've had surgery for it. We know that IVF is not kind to our eggs. So think about preserving embryos or eggs now while you still have healthy eggs. I think that would be a great idea for you. I think I'm onto something. So I hope that helps. And the other thing that I would suggest, if you haven't taken it yet, is N-acetylcysteine. It sounds like you have a diagnosis of endometriosis. If you want to take it right now, you can, or you can take it as you're preparing for your transfer. Either way, that's something that might help. So this next question is from Mira. Here's Mira's question. What can be the next step after a failed IVF? Can one take a break after a failed IVF and do the next one in the next cycle, or is it advisable to do another round immediately? How effective is the laser and IVIG? What supplements can improve egg quality for low AMH, please? Thank you so much. Okay, Mira, here we go. Are you ready? Failed IVF, diagnosis before treatment, right? Find out, what did we learn from this cycle more that we didn't learn before? And then dissect it. What's causing that problem, right? So the other thing is, talk to your doctor about your embryo diamonds. Remember what day the embryos arrested or were frozen, what's the implantation rate of the embryos, are they abnormal, mosaic, all those kinds of things. You guys know what I'm talking about. I don't need to go through it, but that's really important, including the quality of the sperm on the day of the egg retrieval. Ask the doctor, what did you learn about how my body responded to these medications? Was it what you expected? What would you do differently with the protocol, with the trigger shot, with the sperm? If you didn't do ICSI, should you do ICSI? All those kinds of things are really important to talk about. Schedule that post-IVF consult immediately. I hear patients say they called to have their post-IVF consult, or they're just getting calls by a very nice medical assistant, but no doctor has called them to tell them anything. And they make an appointment, it's like 2 months later. So it's super important to use your language, use words to ask for what you need. And after an IVF cycle that doesn't work, it is very important to set up that appointment and get the official reports, including stim sheet, ultrasounds, blood work. So for me, you come to my office, every ultrasound you get your report. Blood work results, you get them sent to you. I'm always going to tell you how many eggs are growing, when I think the egg retrieval is going to be. So you're going to have that information in real time, but I do realize that not everyone gets that. And that's okay. So if you don't get that from the clinic that you're working with, now you know what to ask for. And they'll all have their own system of communicating. And I think it's important to know what their system is. But that's what I would do if a IVF cycle isn't successful. And I have a blog post. I think it is what to do after a negative pregnancy test. And you can actually print out, go to my website, draimee.org, and put in negative pregnancy test. And you'll see actually a list of questions that you can actually print out and bring to your doctor. And I hope that that list really helps you kind of figure out what to do next. But sometimes it's important to maybe regroup, reset, redo. The 3 R's. I just came up with that. It's not really a thing. So this next question is from Maya. So Maya is saying, hi, Dr. Aimee. First of all, you're an angel. Thank you, Maya. Thank you so much for all you do for us. My question is this. I had atypical complex hyperplasia back in November, so my doctor placed an IUD. After 3 months, I did a biopsy and the hyperplasia was gone. I still have the IUD. I did 2 failed IVF cycles with the IUD. Do you think the IUD might have an effect on the number of eggs? Should I remove it for the next cycle? My doctor does not want to remove it until the last minute in case the hyperplasia comes back. I asked the doctor and he recommended removing it right away because he said the IUD, this is what another doctor said, suppresses the follicles. What do you think? It's very hard to make a decision with two opposite opinions without knowing which one is right. Thank you. Okay, Maya, there are a lot of things that can suppress follicles. Number one, birth control pills. Did you take them? Yes or no? If you did, say no birth control pills, right? That suppresses follicle production. I don't think it's the IUD. I have a lot of patients who have their IUDs in during treatment. I don't see that it suppresses production. However, maybe in your situation it does and will. So I'm not going to get in the way of this debate. Maybe we can arm wrestle me and the two other doctors and see who wins. But I would say that my feeling is keep the IUD in. Don't take it out and see how you can change your stim protocol. However, if your ovaries are saying, IUD, you're annoying me, get out of here, I think that's still okay too. The good thing about hyperplasia is your doctor can do a biopsy at the time of your egg retrieval. I've done that before for patients. So that's a way to kind of figure out where you're at with the hyperplasia, and then you'll have a better idea as to whether you need to pop that IUD back in or not. I mean, that's maybe one thing to think about. So this next question is from, and before I go through these, keep going, you guys know that what I'm saying here is just for educational purposes only. My advice is not replacing the advice of your personal physician. I don't know you guys. I love you guys, but I don't know you. Like, we don't have a patient-physician relationship. I just love answering questions so you guys can hear what I would do in cases like yours, but these are not my expert opinions. Okay, I'm going to keep going. This question is from Geraldine. Hi, Dr. Aimee. My husband and I will be doing our first IVF cycle soon. We were diagnosed with male factor low count and motility. We will be doing the sperm DNA frag test and are considering doing the Y chromosome microdeletion test. However, we don't really understand the purpose of the Y chromosome microdeletion test or why it's needed. My husband's 33 years old. His sperm count's 13.8 million with 10% motility. Can you help us understand the purpose of that test? What will it tell us and how will it help us deciding our IVF protocol? Also, is there a difference in the quality of the sperm and ejaculate versus extracted from the testes with regard to the Y chromosome microdeletion? Thanks so much. Okay, Geraldine, this is what I would do. Go through the balls method, and it sounds like you probably already have, right? So look and see if he has a varicocele, and it sounds like you're already seeing a urologist. Look at the DNA frag, and certainly that test can guide you a whole bunch, and it sounds like you're already doing that. Look at lifestyle, labs, the whole bit, okay? But as far as the Y chromosome microdeletion test, the way I think about it is it predicts the future of your children too. So, and it also tells me if what's going on is genetic or not, or something that I could possibly help with. What I mean by that is if something is genetic, like if let's say someone has an abnormal chromosome analysis and the sperm count's low, I'll just say like, I now know what the reason is, and I don't think there's any steroid or anything that's really going to help this improve. Let's move forward with IVF, and it helps you have realistic expectations as far as what the treatment outcomes could be. So with the Y chromosome microdeletion, what happens is that can be passed on to the next generation. So if it's a boy, that boy might have fertility issues like his dad. So that's one of the implications of Y chromosome microdeletion. I would say that if the DNA fragmentation rate is really bad and you don't have access to something like Zymote or maybe even Pixie, then I would say that doing the, what was the question? Is there a difference in the quality? Oh, then doing a sperm aspiration is also an option too, but see if, basically what the DNA fragmentation is and whether it makes sense. If it's super, super high, maybe consider an aspiration. But I would say the answer is yes. I would be talking about all of those things with the urologist and then make a really good game plan and a nice roadmap for success for you guys. But you're thinking about basically all the same things that I would be thinking about too in your situation. And I would say the likelihood of it being a genetic factor is probably pretty low, but also make sure if you haven't done it already to do a chromosome analysis too. So this next question is from Kathy from Los Angeles. Hi, Kathy. My husband and I are both 40. We currently have 3 PGS embryos, day 5, a 3BB, a 4AA, and a 6BB. Of those 3, please rank the best to worst for transfer. Easy. 3BB, the day 5, the day 6, 4AA, and then the 6BB. And then she asked, also my RE wanted me to use a gestational carrier to transfer these embryos. He said I had a myomectomy with 11, that's a lot of fibroids, and 1 failed IVF transfer from another clinic. I had my tushy checked and it came out all right, so I don't know if I need a GC. What do you think? Will a GC give me a better chance of having a child transferring the embryos than transferring in my uterus? Okay, Kathy, here's the thing. I love your doctor because it's so important I don't know who your doctor is, but I'm sure I'll love them. I think it's always really helpful to hear what you would do if a transfer didn't work before you actually have that transfer that doesn't work, okay? So you worked really, really hard for your embryos, and the fact is that getting more, like, it's not promised, right? Because of our age, the likelihood of having another cycle and having more embryos is pretty low. So one thing that you could do in a case like yours, it sounds like your doctor has a gut feeling that there's something uterine going on. So I would listen to his or her gut. And if your gut is like, I really just want to transfer and try one more time, I would say maybe consider doing one more IVF cycle and getting more embryos frozen before you do that. Or maybe save the better embryos for a gestational carrier in case you transfer again and it doesn't work. That's kind of one thing that I would consider doing too. And be sure to do maybe implantation testing and a hysteroscopy too before you transfer, especially with the history of myomectomy that you've had. And also look at the fallopian tubes. When you have had a myomectomy, sometimes the tubes can kind of get a little scarred. And with that comes a diagnosis called hydrosalpinx. So that fluid in the tube can sometimes be embryo toxic and make it very hard. And I go like this because I'm thinking about that fluid traveling down the tube and then washing away an embryo. And that can be pretty tough on an embryo, and I wouldn't want that to happen to you. So just remember, look at the tubes, look at the cavity again, consider implantation testing, and consider another IVF cycle, and take CoQ10. Okay, so this next question is from Nassim. So Nassim is saying, hi, I'm single and a virgin. Cool. I've never tried to conceive before. No problem. I went to a fertility clinic. He just checked my AMH and told me my chance is less than 10%. Also, he said the best option for me is donor egg or donor embryo, not my eggs. My AMH was 0.2. It wasn't checked on day 3. I was crying for 10 days. He also suggested I can improve my chance if I do PRP. Do you think it will help me? I went to another clinic and a new doctor checked everything, and they said that my AMH was 0.275, my FSH 14, my lining thickness looked normal, and my uterus was just 10 by 3 by 6 centimeters. Is there any chance for me to have a baby with this AMH? I eat vegetables and fruits, never smoke or drink. Thank you for help. So, Nassim, here's the deal. The chance for pregnancy at anyone at 42 is just low. That's just what happens at 42. There's nothing, I mean, you are special, you are wonderful, but it just kind of happens to all of us. There's nothing about you and your levels that makes it any worse than anyone else. That's the thing about our age. Age is the most reliable predictor of pregnancy, not so much these hormone levels. So what I would do is say, ask your 45-year-old self and be like, Nassim, you're going to be really pissed off at 45 if you didn't try with your own eggs, okay? And if Nassim at 42 is like, oh yeah, I would be really pissed off if I didn't try at least once with my own eggs, try with your own eggs. Because guess what? You never know what you're going to get unless you try. And trying is just painful. I mean, it's pain in the tummy. It's pain in the vagina. I mean, it's kind of annoying to go through a cycle that doesn't work. Believe me, I know, because that's what the life of a fertility doctor is. It's doing grief counseling every single day. Okay, not quite all day long, but a lot of times of the day, I have to help patients cope with the grief and the loss of a potential egg or embryo from an egg that didn't turn into an embryo. And that's really, really tough. And so I don't want you to have that experience. But if you feel like you have realistic expectations, it sounds like you do, then I would say go for it. However, if you were crying for 10 days because someone told you that your egg count was low at the age of 42, maybe emotionally it would not be a good idea for you to go through a cycle that didn't work and do something that would give you a 90% chance of pregnancy, like using donated eggs or embryos. But for my patients, I always tell them, look, there's no harm in trying, as long as you know what the chances of pregnancy truly are. And no one believes it until they actually see it. It's just one of those things. And the other thing I tell patients is sometimes you don't have to get to the actual egg retrieval to realize that it might not be for you to do the egg retrieval. And then I tell patients, look, you can say that you honestly tried IVF. You don't have to do an egg retrieval to say that you tried it. You can at least go through the motions, see how your body responds to the medications, and then decide, is this something I really want to go through with or not? So that's what I do for my patients. I say, look, let's just show up. Let's try a fertility treatment and let's see what happens. And if it turns out you have this amazing response and I can get at least 3 mature eggs, let's go for it. Let's do an egg retrieval. But if it looks like I'm not even getting one to grow and it's growing really slow, then I'll say, forget about it. We had this experience, so happy we had it, let's move on and let's be a parent and not a patient and get out of the fertility clinic and into the nursery. You know what I'm saying. Okay, this next question is from Tanya. Tanya is asking me this. Hi, my husband's 30 and I'm 28. I was diagnosed with globozospermia. So So that basically means the shape of the head of the sperm, or the sperm shape, is abnormal. We tried ICSI with calcium activation, but it didn't work. With stimulation, I only had 6 embryos. I don't smoke, drink. I'm a bit overweight. I had an entire checkup and everything about me is healthy. Uterus is normal. The lining is normal. Now we're doing IUI with donor sperm. They check my blood and do a follicle scan to determine egg trigger day. We're now in our 4th IUI cycle and it's just not working. My tubes are open. Everything was checked. There are strict rules where I live in my country, so IVF with a donor sperm isn't advised. Holy smokes, you guys. Aren't we lucky to live in the US? I mean, so lucky that we have so many creative family building options and no one tells us that we can't do IVF with donor sperm. But I do know that that happens in other countries. Also, everything that could result in twins is also a big no. So no egg stimulation medication with IUI. Yeah, you just saw my face. That's wild. Only natural ways. So her questions are, do you have a natural way that could help? Why is IUI not working? Or what are reasons that they could not be working? Or even over-the-counter meds? Any tips at all? Thank you so much. Okay, Tanya, step 1, take CoQ10. Step 2, get more sperm. If they're not allowing you to get more eggs, see if they'll let you do more inseminations. Coat the field. Do an IUI before ovulation, day of ovulation, day after ovulation, and see if they'll give you a trigger shot too. It sounds like they're going to do those things. And at the end of the day, find a clinic in a country that will help you, because there are so many places that you could potentially travel to. With the amount of money that you're spending on all this sperm, potentially you can save it for a visa somewhere if you need it to get care. For example, you can go to Spain, you can go to Greece, you can go to Thailand. There are fertility doctors in Barbados. I mean, we're so lucky to have so many great international options. And I talk to these doctors myself. I have patients who go there, who come here, go there, back and forth. So I don't think of fertility as something that is just in California. I think of this as like universal, and I want to see how I can help everybody. So Tanya, reach out to me and I can see how I can help you find a clinic close to you in the country that you're in. You just have to tell me where it is. That will help you reach your goals as soon as possible. You've been through a lot. So this question is from Rose. Rose is from Iran. Hello, Rose. My people are from Iran. For those of you who don't know, I'm Assyrian. We speak Aramaic at home, which means we say kha a lot. We spit on each other when we speak. It also means that we're all born with one eyebrow and a very furry back. That's what I was told when I was born. I'm a woman from Iran. I'm 36 years old. The results of genetic testing is, and she gives me a genetic report that shows that it looks like, see comment, sex chromosomes mosaicism. She's now had 3 miscarriages, all at around 8 weeks of pregnancy. So she's asking for PGD chromosome of X, or PGS, because doctors couldn't give that to me in Iran. Okay, Rose. So at 36 years old, I think you would be a great candidate for IVF. I have a course. It's the IVF class. You can go to eggwhisperschool.com and enroll for the class. I'll take you through A through Z of IVF. And we just talk about it in a really stepwise approach. And it sounds like if you have access to genetic testing of embryos, this is something that could potentially help you have a healthy embryo. So embryos are like diamonds. The beauty of the embryo on the outside is related to something, but not necessarily completely like diamonds, where the beauty on the inside means it's also a beautiful diamond. I know that doesn't make sense. So that's why I'm going to point it out to you, the difference. With embryos, they can be beautiful on the outside, but the only way to know if it's beautiful on the inside isn't with the microscope like a real diamond, but with genetic testing. So the genetic integrity will tell us if that embryo has the ability to turn into a viable pregnancy. And then the quality of the embryo tells us the implantation potential of that embryo. I hope that makes sense. So Rose, I'm sorry for your the pregnancies. I always say pregnancies that miscarried, because you did not miscarry. Those pregnancies miscarried. You did all you could to carry those pregnancies, and keep going. And I hope that your IVF cycle is successful. This question is from Melanie. Melanie is asking, hi, I turned 40 today. I've looked into freezing my eggs this past year, but it's not covered under my insurance and was too expensive for me to move forward with. The clinic I called made me feel very old and discouraged. Well, that's not nice, Melanie. I'm sorry. That was not appropriate. They should not have done that. Every patient to me is young and fertile, no matter what your age. And let me tell you, the older I get, the younger 40-year-olds look to me. Okay. The clinic I called, I already said that. At my age, if I have any chance of having children, would you suggest that if I meet someone, I still haven't met someone, and that's okay, I just naturally try in the next year or two, or in about 6 months to a year, possibly come to you, come to me, or a doctor and get tested and see if I can freeze my eggs. At that age, am I too old? I saw a girl from The Bachelorette posted about you. Oh, that's sweet. And I almost feel embarrassed reaching out with these questions because I know as far as eggs are concerned, mine are considered very old. Thank you for any feedback. Okay, Melanie, let's break it down. Egg freezing is for anyone in their 20s, 30s, and 40s. How do you know if it's right for you? You get your levels checked. What are those levels? FSH, estradiol, and cyclopentane 3, and an AMH can be done randomly. That rhymed, you guys. Okay, then we'll find out how much your eggs are sparkling. Remember from the beginning of the show, when I say sparkle, we drink. The only thing I drink is coffee. So my point is that don't be discouraged. Don't let anyone tell you that your eggs are old, because that's just mean. We just don't do that to women. If a 40-year-old guy walked in here and he wanted a baby, we'd be like, oh, we'll help you. But a 4-year-old woman, I get that. Like everywhere else, people are like, oh, you're old. Don't you know how old you are? My thing is like, have realistic expectations. It's really hard to get pregnant at 40, and the likelihood of your eggs working is pretty low. But 10% versus 0% in like 3 years, I'll take the 10%. But as long as people know that it's 10% and not 100%, and that's the thing. A lot of people wait until they're 40 and they're like, I'm going to be 40 and then I'm going to go see the fertility doctor and then I'm going to do IVF and everything's going to be great and I'm going to have a baby. And I'm like, I wish one day it'll be that easy. But until then, we have to work really, really hard and sometimes do many, many cycles to get enough embryos for women who are even over the age of 35 sometimes, even 25. So sometimes at 25, you might find out that you have levels that suggest that you might go into an earlier menopause. So that's the thing. You don't know unless you get your levels checked. So I'm so glad you asked this question. And I'm so glad that you guys are all listening to me answering this question so that if you are someone like Melanie, you're 40 years old, you're thinking about freezing your eggs, you know that you should still have hope and you should still get your levels checked and maybe consider freezing embryos rather than just eggs, or doing multiple cycles of eggs, embryos, or embryos, eggs, and talk to your doctor about what's right for you. Okay, guys, I'm all done with all the emailed questions. You can go to asktheeggwhisperer.com to enter your question, and then Paula emails you guys when I'm going to answer the question in a given session, so you know when to listen. I'll be doing this next week as well. I haven't decided which days next week until until a little bit later. So I'm going to answer these questions. So here we go. Georgia is asking, what is HGH exactly? And is it something that doctors don't do regularly? The doctor told me he wouldn't. That's correct, Georgia. Not all doctors do it, but many do. The next question is, can a DNC affect the follicle count shortly after when checking on ultrasound? No, DNCs should not affect a follicle count. However, if your ovaries, let's say, are still affected by HCG hormones, so pregnancy hormones, sometimes you can have cysts on your ovaries after a pregnancy or soon after a miscarriage. So I would say maybe wait another month and check them, because if your ovaries are still let's say stimulated and estrogen's high and you have a cyst on your ovary, sometimes you don't see all the follicles, or the follicle count may not be a really good and accurate assessment of what's going on. So question is, do you recommend rest after transfer? If yes, for how long? Thank you for that question. So I recommend butt to bed, butt to chair, butt to couch, butt to toilet, and rotate. And the reason is this: life's too short. Taking a little break and having a seat for a while is really not a big deal at all. I know you can get up 5 minutes after the transfer and probably do jumping jacks and jump rope and get on a treadmill and run 5 miles, and it's probably going to be just as good as resting for 2 days. But this is the thing. Not all transfers work, right? Only a percentage of them work. And in the transfers that don't work, guess what we do? We start beating ourselves up. We're like, oh, it's because I did this, or I did that, or I lifted too much. So just give yourself a little bit of a break. And then don't shame yourself if you had to go do something. It's not a big deal. You can walk around. You can do chores. But I just don't want people doing things like riding a mechanical bull. Okay, that's funny. Okay, this is a great question. I'm preparing for a natural frozen embryo transfer. I was told to monitor LH from day 10 and then start Crenone 3 days after the LH surge. What else do you recommend to test to increase the success rate? Okay, so for natural frozen embryo transfers, I do a little bit more monitoring that. Thing 1, come in for a follicle check. Thing 2, do a trigger shot. Thing 3, check your hormone levels. So look at your estrogen and progesterone levels, and sometimes I even check LH. So the monitoring that you're doing for me is a little bit too hippie. I don't know why I said hippie. It's a little too laid back for me. I'm all about making sure that I have timed the transfer precisely to when I think implantation will be occurring based on what's going on with your body. And so if you're just doing it the way that you're sharing with me, I feel like that's just not as precise as it could be. So next question is, hi, Dr. Aimee. I sent in my questions about a subchorionic hematoma. Wondering if you could talk about that, feeling very lost after the 7.5-week loss, which I'm not sure it's related. Can you please send that question in again? I want to make sure I do not miss it, and I might have answered it yesterday. So just put it in again for me at asktheeggwhisperer.com, and I will get to it next week. Hello, Dr. Aimee. I'm 35, and I just had my AMH done. It was 3.8, and my FSH was 5.2. I've never been pregnant. I lost my left ovarian tube 5 years ago. What's my best chance? So, Ashley, this is what it looks like. It looks like your AMH units are probably from out of the country. And what that means is an AMH of 3 is quite low compared to an AMH of 3 here. What that tells me is when they removed that right ovary, they took half your eggs. And it seems like you should do something as soon as you're comfortable doing it to preserve your fertility options for the future. Freeze eggs, freeze embryos, or both. And also take a look at your left fallopian tube. See if it's open or not. Because if it's not open, because guess what? Even if God touches you, you can still have scar tissue form after a surgery. So check your HSG and see what's going on there. And if your fallopian tube is blocked, you're going to need IVF to have babies. So do multiple cycles to freeze embryos so that you never look back and be like, why didn't someone tell me this? Why? We don't like to have those conversations. We don't like to have the why. Okay. So next question is, what can you tell me about empty follicle syndrome? So what I can tell you about it is there's probably no such thing. Empty follicle syndrome is a very, very rare genetic phenomenon that might be no such thing. And I'll tell you what it could be. It could be a failed trigger. It could be not enough of a trigger shot. It could be that the eggs are super, super immature because of some sort of genetic issue related to the eggs. Which I think I might have seen like once. But to have true like genetic empty follicle syndrome, like a syndrome, I don't think really exists. But when the follicles grow, if you have multiple follicles, you're probably not growing cysts. That can happen if, let's say, you only have one follicle growing. But in general, empty follicle syndrome is an IVF challenge and something that requires careful thought and analysis and a decision. And then you should make some decisions with your doctor as far as what different protocol tweaks you should make next time. And some of the things that I've done for that is, for example, make sure you're checking estrogen and progesterone, ask about the amount of trigger shot that they used, ask about the estrogen level at the time that you did your trigger shot. All of those things are really helpful in terms of figuring out what's going on there. Georgia is saying, I need an appointment. My doctors stink. Okay, let's see here. I appreciate all the kindness that you guys are showing toward me right now. Any tips for restarting ovulation or getting periods back? I have high FSH, low AMH and estrogen, had one miracle baby despite that. I'm hoping for a second. So I don't know how old you are, but I would say that for getting periods back, once your FSH is high and your AMH is low, we're getting to that point where you are, you don't have as many eggs left. It's one of those tricky things where if it's related to age, there's really not much we can do because like we can't go back and your eggs don't grow. That's a dumb question, a dumb thing to say on my part. You don't age backwards. That's what I meant to say. So if it's related to aging, I would say consider creative family building options. However, if let's say your age is under 40 and this is going on, I have some tricks. So one trick is maybe take estrogen, depending on how high your FSH level is, and then monitor it maybe 1 week after the next. And then see if you can bring down your FSH a little bit, then go. What I mean by go is start taking fertility pills and see if you can grow an egg in that way. See if you can somehow trick your ovary into thinking that the FSH is now off the ovary and now can listen to new FSH, and those follicles, hopefully you still have some, can get stimulated. But if let's say your FSH is over 30 and your AMH is undetectable and your age is over 40, what you're going through is just a natural and normal aging process. And there's a blessing in everything, right? We have to see the positive in all these life experiences, and what you're experiencing can just be simply normal aging, but there still might be some tricks up your doctor's sleeve. So see what they say after you suggest taking estrace to see if it can somehow bring your FSH level down, track it. Once the FSH level maybe gets below like 20, then see if taking some fertility drugs could help. Here's another question. At the age of 40, it's suggested that roughly 1/4 of eggs and embryos are healthy. Do you believe that's cumulative, or is that number based on each round of egg retrieval? It's really based on each egg. So I have patients that say, oh, I heard that 1 out of 10 eggs is going to be genetically normal. So if I get 10 eggs, I should get 1 that's normal. And it's like, no. You can get 100 eggs and still get none that's normal, because 90% of the time it's not going to be normal. And that's just really hard. So that's why it's super important for people to learn about their fertility and be given an opportunity to ask questions in a way that's not fear-based but fact-based, so that you don't look back with regret and wish that someone had told you the real deal at an earlier age. And I think a lot of people compare themselves to their neighbors, to their friends, to their mothers, to their sisters. One of the things I hear all the time is like, my mom had no problems getting pregnant. I'm like, but your mom was 20 and you're 40. You can't compare those two. But the thing is that no one told my patient, for example, that she can't compare those two. And that's not fair to her, right? In her head, she's like, I don't have a family history of having fertility issues, so I can wait until I'm 40. And it's like, I want to help people understand what's going on with their fertility. And maybe one day I'll write the rule book, the Egg Whisper Golden Rule Book. And if you follow these golden rules, you can hopefully prevent infertility and give yourself the best chance of pregnancy and decrease the miscarriage as much as possible. Obviously, these things are totally out of our control, because even my patients have pregnancies that miscarry. They even have pregnancy tests that are negative after transfers, after we do all the things that I talk about here. But at the end of the day, I think a lot of people miss some huge opportunities to preserve their fertility and do things at a younger age because no one told them they can do those things. Okay, here's another question. Do you recommend to do ultrasound to check lining for the natural cycle frozen embryo transfer? And the answer is yes. So for a natural cycle frozen embryo transfer, I am even pickier about getting the timing right. Precision is key. Precise timing is so important as far as figuring out the perfect time to put that embryo in. So I think of that embryo as the most important guest in your home. So you want to make sure the lights are on at the right time to accept the guest. You want to make sure that everything's all spiffied up and clean for that guest. And so that when that guest comes in, the embryo just sparkles on that screen. I said sparkle, and that's what I do. Every time I do a transfer, I'm waiting for the sparkle, that little spark of life that's just so magnificent, and it never gets old, ever, ever, ever. It's always fun to see. So I'm going to sign off on tonight's show with this last question. This question is from Nicole. What does FSH mean, and what does it tell you about a person's fertility, and how does it work within the body? I hope that makes sense. Nicole, it makes perfect sense. So this is the thing. If you Google image hormones during the menstrual cycle, do it now. Hormones during the menstrual cycle, click image. You're going to see a chart. It's going to look like this, right? Beginning of the cycle goes up, down, and then it goes like that. Pretty much like that. So FSH stands for follicle stimulating hormone. It's a diagnostic test that we use to kind of understand what's going on with a woman's egg quality, okay? So if the FSH level is over 10, it tells us, or close to 10 even, it tells us that the brain might be working a little bit harder than usual to get a healthy egg to grow, okay? If the FSH level is, let's say, over 15, it tells us, wow, the brain is working a lot harder to get a healthy egg to grow. When you're in the 20s, at that point, there might not be any healthy eggs left. When you're in the 40s and above, it means that your menopause is coming around the corner, okay? Alternatively, AMH is a hormone that stands for anti-Müllerian hormone, and it is also known as always mean or always meandering hormone too, because it can kind of just shift and there can be some variations from month to month, year to year, every 6 months, and that hormone kind of tells us how many eggs you have left. So I combine a patient's age, her FSH, estradiol, AMH level, her diagnosis, like for example, if she also has fibroids or endometriosis or a male factor, and then with all that information, I can guide her as to what I think her chances are for pregnancy, given the treatment that she's considering. For example, IUI or natural conception, IUI or IVF. So you guys all know the questions to ask. Doctor, what's my diagnosis? What are my treatment options? What can I do that's in my control to give myself the best chance of pregnancy at home? And given the family size that I want, what do you think is the best option for me? And so these are very personal choices for you to make with your doctor, okay? It's not about your doctor and what they want. It's about what you want and how you want to grow your family. So that's really important for you guys to know. So I always tell a patient this. I say, this is what's going to give you the best chance for pregnancy with the diagnosis that we have. But what do you want to do and what questions do you have? And I think what's going on with the pandemic right now, I can tell someone something and then they'll leave my office, and I sometimes think, I don't think they might have heard me, right? Because it's hard to like communicate with like a mask on, you know what I mean? So it's super important, you guys, to make sure that you're getting instructions or the diagnosis and labs emailed to you, email described to you. Maybe your doctor can leave a phone message. And the other thing, this is a tip, I can't believe I haven't told you guys this. I actually tell my patients, please record this conversation. Please. I say just hit record on your phone and record it. And then you can transcribe it. You can listen to it later so that you can go home, Google the terms that I use. But I always give my patients a summary of our consult, whether it's a phone, video, or in person. And I don't do in-person consults anymore just because it's so hard to talk with the mask all day long when I'm starting at 6 a.m. Okay, guys. So thank you for joining me today on Ask the Egg Whisperer. I'm going to be here next week, so be sure to enter your question at asktheeggwhisperer.com. You guys are awesome. Please keep making magic happen. Keep sparkling out there. Keep up the great work. And I hope that all the questions that people are asking and the answers that I'm giving are really helpful. So thank you guys for joining me tonight, and have a great night. And I'm going to go sit in a drive-thru right now. I'll see you guys later. Bye, guys.